Hello, my name is Tammy Bio, and I am here to review the psychometrics of the Beck Depression Inventory 2. So today we will be reviewing the purpose of the study, the Beck Depression Inventory 2, and its historical framework, along with the revisions. We will also review method, results, and then discussion. So why this research matters. This presentation is going to examine the psychometric properties of the Beck Depression Inventory 2, also known as the BDI-2, building on previous research by Samar and colleagues. I will also present findings from a sample study, which investigates the reliability and validity of the BDI-2 in 25 women from across the United States. So the Beck Depression Inventory is one of the most frequently utilized self-report measures for evaluating the severity of depression. It is widely accepted and used in psychology and psychiatric settings. It's used in primary care, oncology, autoimmune, or immunodeficiency, cardiac patients. I know I personally have filled them out in urgent cares, primary cares, specialist office. I think it's a very world-renowned, widely used measure. It was developed by Dr. Aaron T. Beck in 1961. His associates also helped with revisions from Dr. Robert A. Steer and Dr. Gregory K. Brown. So Dr. Aaron T. Beck, he is very interesting to research. So if you're looking for something to read over the summer, I highly recommend looking into Dr. Beck. He is also behind the development of cognitive behavioral therapy. So just a very interesting read on him. But he is a professor of psychiatry at the University of Pennsylvania. Dr. Brown is associated with the Perelman School of Medicine at the University of Pennsylvania. And then Dr. Robert Steer is affiliated with the University of Medicine and Dentistry of New Jersey. So the BDI was first published in 1961. It consists of 21 items that assesses various symptoms and attitudes associated with depression on individuals over the age of 13. And throughout all of the revisions, that 21 item measure stays pretty consistent with the exception of one revision. But otherwise, it's typically that 21 item measure. There are typically no subscales reported. The recall period for response is the last 7 days. One thing that does remain consistent through all of the revisions is the 4-point Likert scale, indicating the degree of severity of the symptoms. So 0 is not at all, and then 3 is considered an extreme form of each symptom. And then you have your total scale for scoring, which is your 0 to 9 is absent or minimal. 10 to 18 considered mild to moderate. 19 to 29 is considered moderate. And then 30 to 63 is considered severe. And that again is consistent through several of the revisions as well. Not all of them, but several of them. So revisions began initially in 1971 and were published in 1979. This revision is considered the BDI-IA. While it did maintain a very similar structure to the original version, the revised version places a greater emphasis on that recall period of symptoms from up to the previous week to that day. And it does include a manual with a lot of literature as well as instructions and special instructions. For example, if a participant is trying to lose weight, item 19 is not added to the total score. Again, you have that 4-point Likert scale indicating the degree of severity and symptoms. And then your total score is that 0 to 9 considered minimal, 10 to 16 considered mild, 17 to 29 moderate, and then 30 to 63 considered severe. So the next revision to come out is the BDI-2. in 1996. I will continue on with that version on slide 6 because that is the main point of our presentation, but I do want to get out the latest revision first. So this revision is labeled as the BDI-FS, known as the fast screen. It was previously known as the BDI primary care. This was published in 2002. This shortened version contains 7 cognitive and affective items from the BDI-2 to evaluate depression in individuals with biomedical or substance abuse issues. The recall period matches the BDI-2. So we will review those items on the next slide. But this BDI fast screen is very widely used. Again, this was what I was referring to when I said I've used it in urgent care settings, primary care settings. It is just very it's a lot faster. You go from a 21 item measure to 7 questions. The time period of completion goes from about 10 minutes to, it can be as, about 5 to 10 minutes, about half that time. You still have that 4-point Likert scaling of the 0 to 3 for symptoms, but your overall total score scaling is going to go down. So you have that 0 to 3 is considered minimal, 4 to 8 is considered mild, 9 to 12 is considered moderate, and then 13 to 21 is considered severe. And you can utilize the fast screen in the different varieties of settings: chronic cancer patients, primary care, immunodeficient patients, so a variety of settings, and that's why I think it's just so widely used. So in 1996, the BDI-2 was released. Now, this revision was the most essential revision. It aligned its questions to correspond with the Diagnostic and Statistical Manual of Mental Disorders, and also known as the DSM. I believe right now we're on the version DSM-5, but this aligned with the 4th edition criteria. So items relating to weight loss, body image, hypochondria, and working difficulty were essentially omitted. The same amount of items were placed back in, though. Items were added to the measure for cognitive, affective, somatic, and vegetative symptoms of depression. The BDI-2 was also released in several versions: French, Japanese, Chinese, German, Italian, Portuguese, which we will get to in a second, but a variety of different languages that it was translated into. So individuals are asked to describe themselves in terms of following different areas such as sadness, self-dislike, past failure, or just a couple examples. And so they will see this, and so they will see sadness, and then they are asked on that Likert scale, how are you experiencing these symptoms? 0, not at all, or 3 to extreme, you're sad all the time. So the recall of the symptoms extends for that 2-week period to correspond with that DSM-4 criteria for major depressive disorder. So it aligns with that. And there's also special instructions for items 16 and 18, containing a 7-point rating to increase or decrease in behavior. Again, that 4-point Likert scaling. And the overall total scale is very similar to the original. It's 0 to 13 is absent or minimal, 14 to 19 is mild to moderate, 20 to 28 is moderate, and then 29 to 63 is considered severe. So getting down to the technical evaluation component of the presentation, Almeida and colleagues from 2023 conducted a study on 574 patients. 202 of the patients had cancer. 376 were non-cancer outpatient. Participants were at least 18 years or older, and the data was collected during routine visits to the outpatient neuropsychiatry clinic. Now, of the 202 patients that were cancer patients, 48 were men, 154 were women. Their age range was 30 to 87, with education years ranging from 2 to 27. Now, of their non-cancer patients, 131 were men, 245 were women. Their age range was a little wider because it was a non-cancer patient um, criteria, but it was 18 to 87 with education ranging from 2 to 22 years. So their BDI total score showed great internal consistency with a Cronbach's alpha of 0.91, which indicates excellent, awesome internal reliability of both their primary care and non-primary care samples. So this study just essentially validated the Portuguese version of the BDI2, which I think is amazing. For cancer patients, it assesses the diagnostic accuracy, um, assessing its diagnostic accuracy. It demonstrated that the BDI2 is valid for assessing those depressive symptoms and comparable and reliable and valid to psychiatric disorders. So their study had a critical finding that the BDI2 total scale accurately identifies depressive spectrum disorder within cancer patients. So it was a really great article. I really recommend you guys checking it out. So I did my own technical evaluation. I utilized an unpublished data set provided by Ponce Garcia and colleagues from 2022. I performed a data analysis on 25 women from across the United States. Their participants, they completed an anonymous online IRB approved study through Amazon Interact in which they were compensated $1 for their participation. So those participants, their age ranged from 18 to 59, with education levels varying from GED or high school to bachelor's degree. So the participants completed the BDI2 measure, and their total scores demonstrated high internal consistency, with a Cronbach's alpha reported as a 0.95, indicating a strong reliability, which we love to see. So this is what the measure, this is the different items on the scale. Now within their measure, they did include the two exceptions to the questions and the changing of sleep and the the appetite loss or gain. So this is the mean numbers of the scale items, the standard deviation. And we have our Likert scale range here, our 0 to 3, and then our Cronbach's alpha if the item was to be removed from the measure. So one thing to note, which is on my next slide of my critique of the BDI2. So within the data of the Ponce Garcia and colleagues, sleep loss is shown as an item reliability coefficient. If the item were to be deleted, the Cronbach alpha would actually go up higher to a 0.962. So what that suggests essentially is that if we were to remove that item, our reliability and validity our internal consistency is going to go up. So that item was kind of redundant. That's what it signifies, in my opinion, because the question was, is there changes in sleep? They answered that question and they moved on to, do you have sleep loss? So you're kind of asking the same question, but just in a different way. So it really wasn't necessary within the measure, but that was a critique that I did have. Another critique that I was reading a lot about is that there's a lot of important assessment inclusion for depression in different categories within your medical patients. So cardiac patients there are different inclusions. Our super elderly patients, our oncology cancer patients sometimes. So what that essentially, from my understanding, is that if they're having some sort of like chronic illness, their symptom might correspond and possibly show as a depression symptom, but it might actually be related to a different medical disorder that is ongoing. So that is also why that manual is super important and why you have to be trained to administer and assess and score and provide those interventions, because there's a lot more than just handing somebody a piece of paper and saying, here, oh, okay, you have depression. There's so many different variables and factors which we have learned about through psychometrics and through statistics and through research methods. So overall, I think it is an amazing measure that I have found while researching. It's very utilized throughout the world in different languages for a variety of different patients. I just think it's a very interesting and a great measure to utilize when it comes to depressive attitudes and symptoms. So overall, I hope you guys enjoyed this presentation. If you have any questions, just leave them below in the discussion. I do have a reference page that does not like to come up, so I do have to exit out, and then it is on that screen. For some reason, my reference page hates me. It won't even let me do my hanging indentions, but my references are here. If you have any issues with my references or any questions or concerns, again, leave them below in the discussion. I will be happy to respond. But overall, I hope everyone enjoyed my presentation, and I hope you have an amazing day. Thank you so much.